Heidi Fagan, and I'm an occupational therapist here at Gaylord Specialty Healthcare. And I'm here today to talk to you about visual impairment after a brain injury. Visual function is dynamically interwoven within functional task performance. Visual deficits are a common impairment following a neurological event such as a stroke, brain injury, and concussion. A good majority of the brain we use is involved in vision. The data is variable, but overall data suggests a large percentage of people after brain injury have visual deficits. This can be because patients fail to report the visual impairment due to limited cognition and confusion, and they can be labeled as confused, anxious, uncooperative, clumsy, unmotivated, but still have an underlying visual impairment. These deficits can occur for up to 3 months to 1 year following a brain injury. Some deficits can last a lifetime. Ignoring vision deficits causes invalid assessment and faulty clinical reasoning, which can affect goal setting and a person's independence. Vision is vital for most daily tasks, such as reading, driving, writing, shopping, mobility, dressing, and leisure tasks. After a neurological event, there is significant concern about the lack or limited effort put toward the visual assessment. Sight is what we physically see, the primary sensation for clarity of an image. Someone might have 20/20 vision. Perception is the brain's interpretation of visual information. Here's a visual to help you understand how complex the visual system is. Never forget that the image on the retina is inverted. The cerebral cortex receives the encoded images of the opposite side of the visual field of both eyes. The visual impairment is dependent upon where the injury is on the brain. In some instances, the visual changes that occur following a brain injury require the expertise of a neuro-optometrist. Neuro-optometrists specialize in how the brain processes and communicates information from the eyes and can provide diagnostic information. Patients who may require such services are first screened by the primary occupational therapist. If a neuro-optometry exam is then deemed appropriate, a consult can be placed by the treating doctor. Occupational therapists can assess for visual deficits after a brain injury. However, we cannot diagnose. Occupational therapists will first look at ocular alignment, looking at a person's face for any asymmetries, such as a person's eye turned inward, as you can see in the picture on this slide. They will also look at range of motion, the person's ability for their eyes to move upwards, downwards, and side to side. Occupational therapists will also look at general visual acuity, if a person complains that they have any new blurriness. Another thing that we look at is visual attention, or ability to focus. Occupational therapists help to differentiate between visual neglect and visual field deficits, whether a person has inattention to their affected side versus whether or not they can actually see out of that side of both of their eyes. Occupational therapists also address double vision, conversion and diversion, which is the ability for the eyes to move inward and outwards. We also assess for cranial nerve impairments. A visual field deficit is also known as hemianopia. This means that half of the quadrant of the visual field is missing or unseen. These field cuts are from injury to the brain and not the eyes. This is diagnosed by a neuro-optometrist, and oftentimes prisms are prescribed to help correct the deficit. After an injury to the brain, a person may not be able to pay attention to one side of their environment without prompting. This is visual neglect. For example, they may forget to shave half their face, eat half their plate of food, or start reading in the middle of the line, or bump into walls on one side when they're walking. They may keep their head turned to one side in bed or in the wheelchair, and they may require lots of cues and encouragement that are necessary to help them find objects on their affected, neglected side. Hemianopia. This slide shows an example of normal vision versus someone who has a visual field deficit. As you can see, a person with a visual field cut is unable to see the entire mountain range. Cranial nerves are responsible for eye muscles. Cranial nerve 3, the oculomotor nerve, is responsible for controlling eye movements, eyelid elevation, and pupil constriction, which is the ability for your pupil to get smaller. They may complain of having a lazy eye or double vision. Cranial nerve 4, the trochlear nerve, is a nerve that is responsible for the eye muscles for downward and outward eye movements. It is also responsible for vertical double vision. A person may tilt their head to the side. Cranial nerve 6, the abducens nerve, is a motor nerve that controls the outward movements of the eye. It's also known as a sixth nerve palsy, and a person may complain of double vision. Vision is vital. Visual deficits are a common impairment following a brain injury. Occupational therapy can help, but a neuro-optometrist does make the diagnosis. Thank you for taking the time to watch this video. Please be sure to check out all of our other videos in our brain injury education series.